The next presentation is from Dale again, and Dale's going to talk to us about, ask the question, does the content on a form make a difference to resuscitation conversations? Thanks, Dale.
Thank you again. I'm now going to talk about a project that stemmed from a teaching session that John O'Paulin, who is another one of the house surgeons in Nelson, who couldn't be here today to present this talk, did last year regarding the outcomes of CPR. I'm going to briefly revisit the key points of that talk, discuss the results of a pilot of a tiered goals of treatment form at Nelson Hospital, and in particular whether the content of the new form made a difference to conversations. So on a long day in our first week as new house surgeons, and quite a few times since, we were asked to review a deteriorating elderly patient who had the potential to deteriorate further and even to die overnight. There was no direction in the notes as to whether this potential outcome had been discussed with the patient or their family. So after a discussion with the on-call registrar, then with the patient and their family, in a collaborative manner, we started treatment and discussed and filled out one of our what was then standard not for CPR forms. And being diligent house surgeons, we went back the next day, check on the notes to see how things had gone overnight. We found the green form removed and a note from the patient's team. She's good for 92 for CPR. Now we often hear this in hospital, good for age, but what does good for age actually mean? And does functionally good equal physiologically good? That's a leading question. Now TV paints quite a rosy picture of CPR in hospital, resuscitation in general. Unfortunately, we know that in reality the outcomes are pretty rubbish and they get worse the older that you get. And this is even independent of comorbidity, which further reduces the chance of a favourable outcome. So as a secondary centre, our hospital is staffed with predominantly junior doctors outside of hours. Overnight we have a general medical registrar and a house surgeon covering our wards. So we're often involved in situations where a patient is at high risk of dying. At times there is a CPR, a not for CPR form present in the notes, but we know that resuscitation is wider than just CPR. And often pertinent conversations around these wider aspects are often buried in the notes, often only viewed in retrospect. And sometimes they're not documented at all. So a discussion around goals of treatment, as we're aware, is difficult in the context of a deteriorating patient in front of you, so the default position, unfortunately, can be to escalate, to do everything. And then unfortunately, if there's a form and the patient arrests, we don't do CPR. We felt that this approach was causing distress for ourselves as junior doctors, certainly nursing staff, patients, families, by defaulting to wider resuscitation measures that may not be wanted, it may not be appropriate. So with the support of one of our cardiologists, Tammy Pegg, we piloted a tiered resuscitation form to try and improve, A, the visibility and discussion around these goals of treatment, to make it clearer, particularly out of hours, and then we looked to see whether that made any difference to the conversations. So this was the OtTeR project, Options for Treatment and Resuscitation. We had a look through several form options from Cambridge, Tasmania, and after extensive discussion, selected the Royal Bath University Hospital, which was, say, localised, but plagiarised would also be appropriate, to Nelson Marlborough in a collaborative approach with consumers, junior and senior medical staff, nursing staff from acute medicine, ICU and ED. We initially piloted this form in the cardiology and general surgical departments in Nelson and in wider hospitals, with general medicine and orthopaedics retaining the existing not-for-CPR form. We included a total of 133 patients, 80 with the not-for-CPR and 53 with the OtTeR forms, and then conducted a chart review looking at primarily the visibility of the goals of treatment and the frequency of documentation around discussions of this. whether the form had made a difference. So this graph shows the proportion of patients in which the sealing of treatment in the notes was equivalent to what was documented on the form, which is the first reference after hours for staff unfamiliar with the patient and their context. The information on the OtTeR form shown in green was congruent with the notes. We found 97% of the time, making it a fairly appropriate and representative quick reference. In those patients with a not for CPR form shown on the right, only 65% were for sort of everything but CPR, with 35% having a lower sealing of treatment documented somewhere in the notes, but not evident initially on the form. And certainly this becomes more of an issue the longer someone is in hospital and the taller and the more additions are present of their notes. Documentation around sealings of treatment was present in around 80% of the associated admission notes where the OtTeR form was used, compared with just under 50% with a not for CPR form, which could suggest that the requirement to discuss more in-depth and specific treatment options prompted more regular consideration and documentation of this, rather than just a dichotomous tick, yes or no to CPR. And then this graph shows several other outcomes that we looked at, with the OtTeR form shown in green and the not for CPR form shown in blue. So if we move from left to right, there was no significant difference in the inclusion of patients or their family or whānau in the initial goals of treatment discussions at the time of admission. The documentation of subsequent discussions once the patient was on the ward was no difference between these forms, and there was no difference in the number of organised family meetings around goals of care later on in the admission. Now again, we're a small spot. Obtaining meaningful outcome measures in this area can be quite difficult. The frequency of documentation was an accessible measure for us. The evidence does seem to be that the more discussion is had, the better the happiness and quality of care metrics can be, but we're definitely relying on what is written, which is inevitably second-hand information, may not represent reality, and is almost never the whole story. So overall, we found that having, for us in our hospital, we found having a tiered resuscitation form improved the visibility of goals of care, particularly for staff unfamiliar with the patient, and improved documentation around these goals of care at the time of admission. However, it didn't improve inclusion of the patient or their family or whānau in the conversation, or the frequency of subsequent discussions or family meetings. And as we've heard quite a lot before, it's not all about the form, and I think this demonstrates this. So where to from here? We've adopted the OtTeR framework throughout Nelson Hospital. We've also added a serious conversation guide to the back of the form to give clinicians, and particularly junior doctors, so registrars and house surgeons who are often having these conversations in our emergency department, a framework around what can be a very challenging area of conversation. We're currently re-auditing these metrics now that the form's been embedded for 6 months, and overall we've had favourable feedback from particularly junior doctors and nurses because of the simple framework and reference. Language can be a powerful lens to view perceptions, so I'd like to finish with the word clouds taken from free text sections of the old not for CPR form shown on the left, and the new goals of care treatment form, or goals of treatment form on the right. I think sort of shows the difference when you're discussing goals versus not for CPR quite nicely. I think it's interesting to see the differences. Certainly we're in the very early stages of this. We're learning from other centres that have gone before. We'd certainly appreciate any feedback that you've got around this issue. Thank you very much for your attention again. Sorry to take up twice the time.
Thanks, Dale. Any questions? No? Okay. Dale, my understanding was the 2 different forms were used in 2 different wards, 2 different areas.
They were, yes.
Does that introduce any source of bias? That's
Absolutely.
the first question.
Yeah. So I'd say that While we did try and split it between sort of the cardiology and orthopaedics, general medicine, general surgery, there will still be inherent differences between those, which is why we're now re-auditing in the general medical unit. We'll then compare, now that the form's embedded, with the general medical data from a year ago, not for CPR versus OtTeR. So yes, that's definitely a source of bias. We're hoping to address that with future work.
And my second question is, you had quite low rates of subsequent discussions. My part A of the second question is, who filled out the forms?
Yep.
And what do you think the barriers were to having subsequent discussions?
Yeah, I think it's important to note that it's documented subsequent discussions, and I think that's the first potential issue. In our hospital, often, certainly for the general medical service, the registrar will have the conversation in the emergency department. That conversation will then be followed up on the ward round the next day, most of the time. In terms of subsequent discussions after that, I haven't looked at the length of stay for these patients. I wonder if, I suspect that if the ceiling of treatment didn't change, then it wouldn't have been a documented discussion, and I think that's a relatively low occurrence anyway, potentially for patients that stay on the ward.
Any other questions at all? Yes, we have a question. Very exciting. No, that's okay, right behind you.
My question is, when you're attending and having these conversations with patients, do you have any nursing involvement and support for those conversations?
Absolutely. Yeah.
What support do you have in terms of nursing going to those conversations?
So who's normally there in these conversations is either the patient's nurse in ED, or if you're on the ward, the patient's nurse on the ward, and particularly for junior staff conducting that conversation, often it's a senior nurse in the department that's there for support as well, which does make a huge difference. That's not formalised in any way, that just seems to be, in my experience, how it happens, which is extremely beneficial for those of us who are doing them on occasion. Yep.
Dr. Tripp.
Just a comment. I found those two word clouds really powerful, and it's a great illustration of how important it is to ask the question the right way, because you get very different answers, and it was beautifully portrayed, the two different ways of doing it. I thought that was significant. Thank you.
We should talk about what we're going to do rather than what we're not going to do, Dr. Tripp. One more question. No, sorry, that's the microphone holder. Thank you very much, Tal. That was excellent.